Hello, everyone. Thank you for coming today. My name is Zena Rockowitz. Welcome to the NYU Alzheimer's Disease Research Center Learn at Home series. Today, Dr. Masurkar is going to be presenting a talk called Beyond Memory, Non-Cognitive Symptoms of Alzheimer's Disease. Please note that this event is being recorded. Also, you're muted upon entry, but after the presentation concludes, you can use the raise your hand button at the bottom of the screen to unmute and ask a question. You can also type questions into the chat box. A little bit of information about our speaker. Dr. Masurkar is a physician scientist with a focus on the mechanisms, biomarkers, and therapeutics related to early Alzheimer's disease. Dr. Masurkar received both his PhD as well, his MD as well as his PhD from Yale University, and completed both his residency and fellowship at Columbia. At NYU, Dr. Masurkar wears many hats. He's an assistant professor of neurology and physiology, an attending neurologist at the Pearl Barlow Memory Center, an investigator at the Neuroscience Institute, and the clinical core leader at NYU's Alzheimer's Disease Research Center.
Well, thank you for having me. I'm excited to talk about this topic. I'll just wanted to reshare here. And this topic is near and dear to my heart because it is the focus of a lot of the research that I do at the center. And I'm actually going to be not only showing some general facts about this topic, but I will also pepper the talk with actual data from our Alzheimer's Center to really show all of you how participation in our study is really, moving things forward in the field. And so I'm going to talk about three broad categories of non-cognitive symptoms of Alzheimer's disease, and focusing on one symptom in each of those categories. So I'll talk about psychiatric symptoms with a focus on anxiety. I'll next talk about sensory problems with a focus on the sense of smell or olfactory function. And I'll end with a discussion of motor symptoms in Alzheimer's disease with a focus on gait or walking. And so I wanted to start with a general view, the classic view of Alzheimer's disease, which I'm sure a lot of you have read, that it is a disease of aging that causes decline in cognition, as demonstrated by this graph. All of us, as we age, we do slow down cognitively. That's sort of normal aging. But when it comes to Alzheimer's disease and related dementias, that downward line is a little bit more severe or a lot more severe, thereby progressing to a pre-dementia stage called mild cognitive impairment or MCI, or full dementia, where there's a loss of independence. And this is coupled with shrinkage of the brain that can be seen on MRIs, as I show below the graph. And it's thought that this decline in cognition and memory and other forms of thinking is due to two abnormal proteins that are deposited in the brain, amyloid and tau, which is depicted to the left. So the blue arrow is focusing on the tau-based tangle pathology that's in the brain cells, in the neurons, and the amyloid plaque pathology, which is outside of the neuron, sort of in the vicinity of the brain tissue. And so this is the classic view. And a lot of the medicines that we use to treat cognition, to treat Alzheimer's disease, have been really focused on cognitive outcomes, on functional, day-to-day functional outcomes that relate to one's thinking and cognition, or attacking amyloid and tau, the biology of the disease. But I think what's come to us now over the last several decades of taking care of Alzheimer's patients is that this is really a disease that affects the whole body. It's also a disease that's impacted by the whole body. And what I mean is that the brain is, not in, in a silo separate from the rest of the body. It may be in a separate compartment in the cranium protected by the skull, but it is intimately connected with all of the other organs and parts of the body. And I think that we've increasingly recognized that this is really important to understanding Alzheimer's disease and taking care of our patients and finding treatments. And so we've over the past several decades, we've learned a lot about how Alzheimer's patients can have problems with their sensory function, like smell and hearing and vision, and they can also have problems with mood and behavior, like from anxiety, depression, sleep problems, walking problems, walking and gait issues, the impact on heart function and blood vessels, the role of gut health and the microbiome, meaning the bacterial populations that are in the gut itself. And I think that we're gradually moving to a whole body perspective of this disease and how this works in both ways. So understanding and appreciating how someone with Alzheimer's and a related dementia has problems outside of cognition, outside of the brain, but also recognizing how these symptoms, these other organs, can impact the brain as well and impact brain health. So the arrows sort of go both ways. And so I wanted to start with one category of symptoms, the psychiatric symptoms. And this is a graph of how psychiatric symptoms in Alzheimer's disease manifest across the different stages of dementia. And we've noted various categories. And this data derives from over 200 participants from the NYU ADRC that were followed in time. And this is sort of a bar graph showing the frequency of different categories of psychiatric symptoms going from preclinical stages, that's called, for example, subjective cognitive decline, to mild cognitive impairment, and the increasingly severe stages of dementia. And the various categories include psychosis, which are like hallucinations and delusions, activity disturbances, so sort of restlessness, or obsessive compulsive kind of activity, aggression, diurnal disturbance, which just means the sleep cycle is flipped. And then the other two categories are mood related, depression and anxiety and fear. And what I wanted to point out was that there's a clear timing pattern to the evolution of these symptoms. So very early on, you'll see that the dominant symptom is actually anxiety, whereas later on in the course, you get more of activity disturbance, psychosis, and aggression. Now, we borrow from other fields to treat these symptoms. We use non-pharmacologic methods like lifestyle, psychotherapy, environmental changes to handle these symptoms and advise patients and their caregivers. But we also use medications essentially borrowed from the psychiatric field, to treat these symptoms. But I think there's still a lot that we need to learn, and I wanted to use anxiety as an example of that. So what do we know about anxiety in Alzheimer's disease? So as I mentioned, anxiety is very prominent in the early stages, and it increases across the spectrum of the disease. It's not just that anxiety is common in general. It is common and is common in young adults, especially, but it's much higher in the memory disorders population than it is generally in older adults. So it is clearly linked or associated with the condition. It's also not just limited to worry about memory, and I would also add that it's not clearly just related to the degree of memory impairment or concern. It is, to me, somewhat of a separate category of symptom. And it does also correlate with many biological measures of Alzheimer's disease measured at the level of imaging, like PET scans, spinal fluid analysis, and plasma markers. And these relationships are distinct from depression. And this figure to the right is actually some data that we've looked at in our center, showing that plasma levels of a particular Alzheimer's biological marker, which is the tau to amyloid beta 42 ratio, is distinctly elevated in Alzheimer's disease patients with anxiety versus those who do not, and which is shown in panel A. And in panel B, we show that there really isn't any difference in this marker when you divide the population by depression. So clearly, anxiety, in my mind, is associated, linked somehow with Alzheimer's disease markers and perhaps even severity. We also see that the genetics of Alzheimer's disease can influence anxiety as well. So those who carry the ApoE4 gene, which is a risk factor for Alzheimer's disease, can also elevate the risk of anxiety at various stages. And this is this is not from the knowledge of knowing you have the gene. This is separate from that. This data is from populations where that knowledge is blinded to the participant. Anxiety has also been importantly associated with faster progression, which is shown to the right. Again, this is data from our center, the NYU Center. If you divide your group into anxious and non-anxious people who begin in the sort of pre-dementia, very early preclinical stage, the folks who have anxiety are in the solid line. They progress. They have a higher probability of progression earlier on, whereas the non-anxious persons are sort of slower to decline. And this can also be visualized in the graph below when you look at degrees of change per year, sort of a rate. There's also been studies alluding to or suggesting that treating anxiety with the normal methods that we have can be associated with slower progression, which is quite fascinating. But what do we not know about this? And sort of to the left is a sort of a cartoon that we designed for a paper showing the multitude of pathways that might link anxiety and Alzheimer's disease. And I don't want to go through every single one, but basically we don't know which is the chicken and which is the egg. Is it that the Alzheimer's disease is driving anxiety and these other psychiatric symptoms, or does the anxiety arise and then make the Alzheimer's worse, or is it both? Another question that we're not clear about is where in the brain does it arise from? There have been some studies from our group and my group in particular and others that have linked particular brain circuits to the anxiety symptoms, which is very intriguing because it does then suggest that the anxiety is arising from the disease itself. This notion of anxiety and faster progression, well, is it actually causing acceleration, or are the anxious persons just a different type of patient? Are they a subgroup that is just more at risk, or they just have a faster progressing version of the condition? And I think that another tantalizing question is, does treating anxiety early on prevent the onset of Alzheimer's or slow down the progression? We don't clearly know. This would be ideal for a clinical trial, and it's something that I've been wanting to work on myself. And somewhat linked to that is, are there better treatments? I think that the tools the medications that we use to alleviate anxiety in our patients are borrowed from psychiatry. They can help. I think they can help a lot. They can help some patients, but they're not perfect. They're not ideal. They can have side effects too. And so can we, by understanding the biology of anxiety in Alzheimer's disease, come up with better treatments that can be used to make people feel better, but also to maybe impact the Alzheimer's disease itself? And so these are very exciting questions that my group is working on, that our center is working on, and others in our field. But what do I do now? What do I advise my patients and their families? Well, I think that stress reduction is really important. I think we live in a stressful world. I think we're exposed to a lot of stress more easily these days. And I think that it can have an impact on our health, not just the mind, but our whole body. And I think it's really important for all of us to assess our sources of stress and try to alleviate those as much as possible. Sometimes we can't because we have stressful jobs, we have stressful life situations, but we can use tools like mindfulness, counseling, etc., to help deal with that stress. Other things could be treating the medical sources of stress and anxiety. For example, if you're having trouble sleeping, well, that's just going to compound the anxiety and stress. So working on sleep, or using exercise, aerobic exercise in particular, as a means to alleviate stress and anxiety as well. And of course, if the symptom is truly consistent and pervasive and needs to be treated with medication, we will do so. And so discussing with one's care provider about appropriate medication is obviously another thing that we can do. So switching gears to the next category, I wanted to talk about sensory dysfunction. And so, the senses have been a fascinating topic for centuries. It's the way that we can experience the world. This is actually a painting. This is actually my own picture. I was in the Rijksmuseum in Amsterdam last summer at the Alzheimer's conference, and I happened to see this painting. It's called The Merry Company, from the painter Elias, painted in 1629, and it's called The Five Senses. And so apparently the different groups here are sort of corresponding to the different sensory domains. Apparently, obviously, the person with the instrument here is hearing, and then you have I think touch in the back here, and there's taste with the food. I believe the dog is supposed to represent smell, and so on and so forth. And I think that the senses were considered a way to enjoy life, to seek pleasure. I think that was the point of the painting here. But they're also a window to the brain. We often can study the senses to better understand how the brain works and how it doesn't work. Sensory problems can obviously be distressing and thereby limit our interaction with the world. They can also complicate cognitive problems. If you can't hear and you can't see for other reasons, and you have a memory problem, well, it just makes your ability to understand and communicate and be independent even more difficult. There are also safety issues to having sensory problems. The good thing about sensory problems is that many of them, maybe not the one that I'm going to talk about, they can be treated to some degree with hearing aids, with glasses, with cataracts surgery, for example. And what is fascinating about sensory problems in the context of Alzheimer's disease is perhaps they allow us to have easy ways to detect risk or track dementia at early stages. And so the one sense that I wanted to talk about was the sense of smell, and why? Well, the sense of smell is, I think, the one that has the most intimate relationship with memory. And so there's this famous writer, Proust, who wrote about these Madeleine cakes. And when he would smell these cakes, he would be brought back instantaneously to memories of his mother, which sort of really highlights the connection, the literal connection between the brain circuits that process smell and the hippocampus, which is the memory center of the brain, which so happens to also be one of the first areas of the brain to be affected by Alzheimer's disease. And and smell is also unique among the senses in that it's more directly processed by the brain, as depicted to the right. Other senses, such as vision and hearing and touch, they don't go directly to the higher areas of the brain called the cortex. They have to be first relayed by a part of the brain called the thalamus, which is like the router. And smell is the only one that has almost a direct relay to cortex. And I think that's another reason why it's very fascinating in this context. The other part of olfaction that's very interesting is that taste is essentially driven by the sense of smell, by olfaction. And I think we can all appreciate this because when we have a cold and our noses are stuffed, we really can't taste anything anymore. And also a lot of people who, experience loss of smell for other reasons, from smoking or allergies, will also have their taste affected as well. And so what does the data show with Alzheimer's disease? Well, we know that olfactory sense or sense of smell does decline with age, naturally. And there's a loss of sense of smell that's even beyond that, that's very particular to a couple of neurological diseases of aging. In Parkinson's disease, research has found that olfactory sensitivity declines. So what olfactory sensitivity means is that you need a higher concentration of that odor to actually realize it, all right? And that's supposed to be very peripheral, probably in the nose. What are called the olfactory sensory neurons in the olfactory bulb are affected in Parkinson's disease, and that's probably why those patients have that kind of olfactory loss. In Alzheimer's disease, it's a bit different. It's not a concentration problem. In Alzheimer's, it's the ability to identify an odor, to give the name of an odor and distinguish it from other odors. And this is separate from a language. So even if you do a study and you correct for the language problem, you still will see the same deficit. And overall, olfactory deficits, loss of smell, associate with biological markers of Alzheimer's disease. They portend a faster progression, and they actually associate with increased mortality overall. And this is sort of highlighted by the graph here. This is a study that I did with colleagues at Columbia, showing, to the left are sort of lower scores on sense of smell tests, and to the right is higher scores, and the degree of mortality on follow-up, goes down the better you score on the olfactory test. We don't know the association with that. Maybe it's linked to nutrition, maybe it's linked to dementia risk, or a combination. We also know that smell is a critical factor for the emotional experience of socializing, nature, food, and drink. And we also find that people who lose their smell are more at risk for mood issues, depression, and lower quality of life. It can impact taste, as I mentioned before, which affects our food consumption, contributing to weight loss and malnutrition. And there's a safety issue. So can be an inability to detect or identify dangerous odors, like a gas leak or smoke from a fire, or the taste of spoiled food, and that can put patients in harm's way. And so it is important that we study this further. So the picture to the bottom right is the UPSIT smell identification test that we use in the ADRC to study the sense of smell. It was designed by the University of Pennsylvania as a research tool to quantify the sense of smell. But what do we not know about smell? So there's a complicated circuit depicted to the right. for processing odor information, but we don't really know where in the brain does that olfactory deficit in Alzheimer's arise from. I don't think it's from the nose or just after the nose. I do believe it's probably deeper within the brain, and I do hypothesize that the hippocampus, which is the brain structure for memory, plays a key role in that olfactory deficit. And so we are doing research to better address that question. Why do olfactory deficits predict progression? What does that mean? Just like with anxiety, are they identifying a subset of patients that are at higher risk? Is losing smell actually causing a faster progression somehow? And how do the olfactory deficits that we acquire from other conditions like COVID-19 predict cognitive decline? Does that have anything to do with our risk? And we are trying to study that as well. Similar to anxiety, will treating olfactory deficits slow down or prevent Alzheimer's progression? And are there more specific ways to treat the olfactory deficits in Alzheimer's disease in particular? And so what do I advise? Well, this is a tricky one because I think we have less tools to use for the sense of smell in terms of its treatment. When it comes to other conditions, often the sense of smell can return, and it's just a matter of time, like COVID. In many cases, the sense of smell does return, or one can use in inflammatory conditions or allergies, steroids or treating the actual insult to improve. And I think in some cases, brain trauma that's causing olfactory deficits, one can use olfactory training to improve the smell. But I don't know if those are really applicable to the loss of smell in neurological diseases like Alzheimer's. But I do feel that where it comes to play in practice could be that if one is seeing patients with olfactory deficits and there's also a concern for memory, well, that I think further warrants neurological evaluation. Maybe this person should be screened for a memory problem like mild cognitive impairment. I also advise that just because you lose your smell and therefore taste, you don't want to add a bunch of salt and sugar and fat to the food so that you can appreciate it more. I think that can lead to unhealthy eating habits. So something to be aware of. And there are maybe other ways to enrich the food so it tastes better with spice and herbs. Be aware of the safety issues regarding olfactory deficits. So, in terms of smoke and gas or spoiled food, for example. And maybe it's advisable that we should pay more attention to weight and nutrition in persons who have loss of sense of smell. But I think this is a field that warrants a lot more study so that we can come up with practical information for patients and their families. So I think there's a lot more to come, and I will make a little bit of a sort of socio-scientific comment that I think that the COVID-19 pandemic, I think, reintroduced the medical community to the importance of smell. And I think that because of that, you're going to hear a lot more about smell screening and maybe even treatments for that in the coming years and decades. And last, I'd like to wrap up with motor symptoms. So motor symptoms in Alzheimer's disease. So motor symptoms can be present in Alzheimer's disease and related dementias. I mean, I think we normally think about Parkinson's as having primarily a motor phenotype, a motor kind of pattern, but you can find them in other dementias as well. And these can come in two flavors. You can have too much motor activity, like tremor, or involuntary sort of non-rhythmic movements like dyskinesias or choreas. Chorea is famously found in Huntington's disease, or something like alien limb phenomenon, which can happen in a condition called corticobasal degeneration, or a very atypical form of Alzheimer's disease called corticobasal syndrome, where the arm is sort of moving on its own. What I also see a lot is sort of reduced motor activity, whether it be stiffness, a loss of dexterity in the hands, outright weakness, imbalance, and sort of a slowness to the movement or an irregularity. And I wanted to focus on gait. Gait is such an important motor feature for human beings because we are upright. I mean, it's sort of one of our defining characteristics that we can walk on two legs. And it is something I think we take for granted, that it is a very complicated task that involves a very broad set of computations coming from the higher brain all the way down to the nerves and muscles in our legs. And anywhere along the chain, if one has an issue, that can impact walking, even in a very subtle way. And so some of this network is depicted to the right. It's even more complicated than this, but there are various age-related conditions that affect various aspects of this complex motor circuit. When we look at walking, we can actually analyze it in a lot of ways. I mean, the easiest way to look at it is the speed. I get that comment a lot from patients and their families. The walking got slow. But you can look at the stride, how far apart the legs are, the stance when a person is standing, how narrow or wide apart their legs are, how their feet are turned out, the swing of the legs, how much swing there is, how symmetric their walking is, comparing left to right, and also the variability. You can see people who can maintain a constant speed, whereas some people can maybe go slow and speed up and slow and speed up. And some of these changes are sort of not very noticeable to the naked eye, and this is part of why we're doing some research on this in the ADRC. So what do we know about gait and Alzheimer's disease? Well, there's a lot of work on how changes in gait, in walking, specifically slowing, can predict cognitive decline. And such changes in gait, just like with anxiety and the sense of smell, can correlate with biological markers of Alzheimer's disease and the ApoE4 gene. And some of the data from our center is actually shown to the right. So here is looking at the link between blood levels of tau, specifically p-tau 181, and the variability in gait. And the way we look at gait in the ADRC is through this digital walkway that's shown to the left and below, which sort of, our participants go back, and some of you may have done this, you walk back and forth 8 times, and the sensors pick up a lot of variables about the walking. And one of those variables that we can compute is how much did the speed change from lap to lap. And what we're finding is that some of that change in the velocity from lap to lap. I was just going over what we know about gait and Alzheimer's disease, and going over some of the findings that we've gotten from our own studies at the ADRC, showing that the variability in the gait can actually correlate with blood markers of Alzheimer's. And what's also quite interesting that I won't be able to get into is that different features of one's walking can correlate with different markers of Alzheimer's disease. So for example, the average speed may correlate with one measure, and maybe the symmetry between right and left may correlate with another. And so this may be a very non-invasive and cost-efficient way to kind of assess people at very, very early stages. So what do we not know about gait and Alzheimer's? I think we need to get a better handle on what are the best ways to characterize walking quantitatively and predict and track risk for dementia. Getting a better handle of where in the brain does Alzheimer's impact to affect walking, And lastly, just like with the other symptoms, can treating walking mitigate the onset of Alzheimer's disease or progression? I mean, we often talk about aerobic exercise and preventing Alzheimer's or treating Alzheimer's. And I think that part of that, of course, is, heart health and mood and all the other things that exercise does to the body. But maybe it somehow directly engages these brain circuits for walking in a way that can ameliorate them or protect them from further damage. I think that that's a very exciting avenue to pursue. And so what do I advise for walking problems, motor symptoms in my patients? So for severe problems, of course, I think physical therapy is critical. Physical and occupational therapy are critical. And the use of assistive devices is important to prevent injury from falls, etc. For those patients who have Parkinson-like symptoms, Parkinson's disease or Parkinsonian-like problems with walking, one can discuss with their clinician about using Parkinson's medications. Of course, these come with benefits for the walking, but also side effects, and that has to be discussed with one's physician or other care provider. And I also always think about what other medications that a patient is taking how that might impact their walking, whether it is some medications that are used for behavior, or even medications that are used for cardiac issues or for blood pressure, for example. So all of these things need to be taken into account when trying to treat walking problems. But I think the key thing is staying active and staying active safely. So just to summarize, I hope that you could take away that these non-cognitive symptoms, psychiatric, sensory, and motor, really do impact the patient and caregiver experience. And specifically, symptoms like anxiety, loss of smell, and walking changes are found early on and can associate with biological markers of Alzheimer's disease and progression. And therefore, this fuels our research to better understand the biology of these symptoms, how we can treat them better, and how they can be used to develop early detection strategies and therapies to slow down or prevent progression. So I'll stop there, and I'm happy to take any questions or comments. And apologize about the technical glitch there in the end.